I wanted to welcome everyone. I'm Jeffrey Goodman, Director of Marketing and Development for the YMCA of Northwest Louisiana. We're so pleased to host today's event. Ochsner LSU Health Shreveport is one of our great community partners, and we love to find ways to collaborate to make days like today happen. The Lash Family Y that you're in opened on January 27th, and today is actually the first community event we are hosting in this new gymnasium. I'm going to let Amy talk about this incredible program we have today, but before I do, I just wanted to say a couple of things. Number one, if you're an Ochsner employee, we have a special membership program available to you. If you're interested, please talk to the front desk before you leave today so they can provide more information. Lastly, I look at the Y more than anything as a community center. To really bring emphasis to that role, we launched a new initiative a couple of years ago entitled Shreveport-Bossier, My City, My Community, My Home. This initiative consists of two components: a weekly podcast interview series and periodic panels and events like the one we're having today. To date, we've published 101 podcast episodes, and today is the 9th event that we've hosted. You can find video of every episode and every event, including today's, which will be uploaded over the next week on the YMCA of Northwest Louisiana's YouTube channel. I hope you'll look into it, as I think this is an example of some of the great work that the Y is doing for our community. Thank you so much for being here. Have a great time. And now I'd like to hand things over to Ochsner LSU Health Shreveport Comprehensive Stroke Program Clinical Educator, Amy Tomlinson.
Hello, everybody, welcome. I want to take a minute first to thank our sponsors, Paul, Sarah, Encompass, and ADOC for helping us to make this event a success, and especially the YMCA. Without you, this would not have been possible. So thank you to everyone. Thank you to all our volunteers that are here. I'm really excited about this event. We're super passionate about stroke care, and we want to take this Stroke Awareness Month to really focus on prevention and improving the health and wellness of our community. And that's the whole idea behind this event. So thanks to everyone who's coming to try to help encourage our community members to take charge of their health and to prevent stroke. That being said, I would like to welcome our first speaker and our MC for our event, Dr. Rahul Shah. He is Assistant Professor of Vascular Neurology and Neurocritical Care and Fellow for Neuroendovascular Surgery. And he's going to be talking to you about stroke awareness and BEFAST. Dr. Shah? I can work this.
Hey, thank you guys, and thank you for all of y'all for being here, and hopefully this event helps the community like we hope it does. So my name is Rahul Shah. I am going to be talking about why strokes are important. Why do we even need to have an event like this? What is the significance? Why do we have a Stroke Awareness Month? And what are the warning signs and symptoms that each one of us should know about so that we can act quickly and hopefully get a patient having a stroke the treatment they deserve and can get. So BEFAST for stroke. So first, what is a stroke? A stroke is an event or a sudden event that causes damage of brain cells because of loss of blood supply and by default loss of oxygen to those cells. And stroke is an absolute medical emergency akin to a heart attack, as we call it. And 1.9 million brain cells die every minute that they do not receive blood supply. And so, like I will probably keep harping on, and others after me will, time is of the essence. So just a quick update, what type of strokes, because this often confuses people. There can be three major types of strokes. One is an ischemic stroke, which are the most common. This is because blood supply to a part of the brain stopped because of a clot that blocked the blood supply. The other one is a transient ischemic attack. A lot of y'all might have heard this term being called a mini stroke. Had some family member mention this or have one of these events. This is where a clot blocks the blood supply for a few minutes, but luckily for the patient, the blood supply pushes the clot away or dissolves the clot, and the symptoms improve immediately. The warning part for this is that typically somebody who has a mini stroke is at a very high risk of having a big ischemic stroke soon after. So they should still be seen in a hospital and their risk factors be taken care of. And the last one is a blood vessel busting open and causing what's called a hemorrhagic stroke. All of these result in brain damage. And again, busy slide, but every part of the brain, there is no not important part of the brain. So every part of the brain has different functions. So depending upon what part of the brain the blood supply was stopped, the patients can have varied types of symptoms ranging from speech to weakness to numbness in some part of the brain. Now, why is knowing about stroke so important? Some numbers over here. We all like numbers, but these are not good ones. Every 40 seconds, someone in the United States is having a stroke. That is pretty startling. Stroke is the 5th leading cause of death in the United States and the #1 cause of disability in the United States. And women, previously believed that women are safer from having strokes, but that benefit changes after menopause, and 55,000 more women are having strokes than men. And 1 in every stroke is in a person who's had a stroke before. So if you had a stroke, your risk of having another one increases exponentially, and which is why it's even more imperative that you get the right care. Some more numbers. Each year, 795,000 people in the United States has a stroke, and like I mentioned earlier, the #1 cause of disability. This graphic or this map is a little startling. I know we love our purple here in Louisiana, but this is not a good purple. This is bad. The dark purple actually means higher number of deaths from stroke, and we are, as you can see, the South is actually called the stroke belt. For this reason, we have the highest death rate from strokes in the United States. And like I said, this is one purple we should try and get rid of. And again, all of those numbers don't matter. At the end, just the only 2 facts that matter for everybody over here and everybody in community is strokes are preventable. The best way to treat a stroke is by making sure that it doesn't happen in the first place. And if somebody is having a stroke, it is treatable or reversible if they get the right care at the right time. So what are the risk factors, or what do we as a community need to look out for when somebody may be having a stroke? The mnemonic BEFAST, y'all will probably hear and see that put around all over today, stands for B, balance. If somebody is having sudden onset or new onset issues with balancing themselves. Vision, eyes, if somebody has a sudden loss of vision in one eye or even both eyes sometimes. Face, if you see drooping of the face, y'all have all probably seen images on Google or on stroke awareness printouts that show a patient with a drooping face. Remember that. Arms, so arms and legs, if somebody has weakness in any one part of the body, that is significant. Speech, if somebody has either slurred speech or is having difficulty getting the right words out, all these things can be signs of stroke. So even if a patient or an individual has one of these symptoms, that could be the sign of a stroke going on. And in that case, T is probably the most important letter because it stands for time. Call 911. Time is of the essence, and we're going to have Dr. Chokhawala talk about the treatments that can be given to stroke patients later, but those only matter if a patient reaches a stroke center, a comprehensive stroke center, in the right amount of time. And then these are some of the risk factors. The tick marks stand for all the things that can be reversed or controlled. And that's the significant part I want you guys to take home from this, that a lot of the risk factors, major risk factors for stroke can be reversed. Dr. Chokhawala is going to talk about some of the risk factors for stroke more in detail, but that's basically it for me. So thank you. And if you all identify any symptoms or signs of stroke, act quickly, guys. Thank you. And then now we're going to have the Soto Parish EMS Training Officer and Paramedic, Brent Crawford. Brent serves on the State EMS Task Force and is a Louisiana Emergency Response Network representative for Region 7. He'll be coming at 10:30 to talk to us about pre-hospital stroke care. Thank you. All right, guys, our next speaker is going to be Mr. Brent Crawford. He is a DeSoto Parish EMS Training Officer and Paramedic. He's on the State EMS Task Force and is a Louisiana Emergency Response Network representative for Region 7. Please welcome Mr. Brent Crawford.
All right. Good morning. Thank you for having me here. I'm going to go over, if I can figure out how this works. There we go. Just a little pre-hospital EMS stroke care, kind of what to expect when you call 911 for someone having a stroke or for yourself. I can't see this. Let me get up here. So Dr. Shah kind of already went through some of the statistics. So according to the CDC, every 40 seconds, someone in America has a stroke. Every 3 minutes and 14 seconds, someone dies of stroke. And every year, more than 795,000 people in this country have a stroke. And about 610,000 of those, it's their first or a new stroke. And the majority of those patients are being transported to the hospital by EMS. Okay? Okay. Okay. Stroke care begins with that initial 911 call. So whether you're calling for a loved one or for a family member, EMS is going to start that initial treatment when you call 911. So when you first call 911, you're going to be connected to an emergency medical dispatcher. Go ahead. Okay. So when you first call 911, you're going to get the 911 representative, which is an EMD, an emergency medical dispatcher, and they're essentially going to take the call and then give you some pre-arrival instructions. And that could be something as simple as making the patient comfortable. They're also going to ask you a variety of questions because stroke can mimic a lot of different things. Stroke can mimic low blood sugar. Stroke can mimic a seizure. So they're going to be asking you a lot of questions, and it's very important that you give them very good information as to what is going on with the patient or with yourself when they call. So after you speak to the emergency medical dispatcher, they will page out the nearest EMS unit, and they will give a report basically of what you've called in your report to the EMS unit that's going to take care of the patient. The descriptions could be anything from my loved one doesn't feel well, or they're just very sweaty, or they're confused, or they have a headache. Stroke can have a lot of different symptoms, and it can also mimic a lot of different things. So it's very important to get that really good pertinent information to the EMS dispatcher so they can relay it to the ambulance. So again, give EMS, when they arrive on scene, give EMS any and all information you can about the patient, about their condition. The most important thing you can tell EMS is when did the symptoms start. A lot of times we get called out early in the morning and they say, hey, last night my dad went to bed and he was fine and we woke up and he was like this morning. So obviously they don't know when the symptoms started, but if you can help us narrow down the window of an hour, 2 hours, 4 hours, whatever it may be, it really helps us get that patient to definitive care quicker, and it's also going to allow us to establish that time frame so we can let the hospital know when the symptoms of the stroke started. So again, we'll get there, we'll get the information from whoever called 911, and then we'll do our initial assessment. That includes taking vital signs, so blood pressure, an EKG, checking a blood sugar, checking your pulse ox, just the same thing we would do to every other patient, just trying to establish what exactly that patient is going through at the time. So if the patient is determined to have stroke-like symptoms, if we've ruled out that it's not blood sugar, it's not a seizure, and we've established that this could be a possible stroke, then we'll do a little more comprehensive test. Dr. Shah talked a little bit about the BEFAST, so we'll do BEFAST or our own kind of version of BEFAST on scene. If they are BEFAST positive, we'll go on and do a VAN test, which is just a little more of a comprehensive test. It kind of tells us if the patient possibly might be having a different type of stroke called an LVO, and it just lets us do a little more comprehensive test as to the severity of that stroke. So again, we're gonna do the same BEFAST that the public does or that the hospital's gonna do, but then if they are BEFAST positive, we're gonna go on and do that more comprehensive VAN test. So following doing all of those things, we're gonna put them into the ambulance and transport them to the hospital with the most definitive care possible for stroke. They're gonna get IVs, they're gonna be reassessed every 3 to 5 minutes, we're gonna make sure that their airway's clear, and we're gonna really monitor that patient closely. Basically, our job's to not make anything any worse and to get them to definitive care as quickly as possible. All right, so time is brain. So just like when you have a heart attack, the longer it takes to get to definitive care to get that stent in, the more damage that is done to the heart. So we want to get these patients to the most appropriate facility as soon as possible to help them reestablish blood flow to their brain. So 4.5 hours is typically the window that the hospital can give medication for those clots. So we really try to establish when the symptoms started, how long they've been going on, what were their initial symptoms, how they've presented with us, and anything pertinent we can to help that patient when we get to the hospital, have them expedited very quickly into the hospital's care so they can go quickly to CAT scan and start getting that definitive treatment that we can't provide on scene. So once we get to the ER, most of the time, we've already got IVs established, we have them on oxygen, we have their vital signs, and we're gonna take them straight from the ER doors to CAT scan. Now, sometimes we may move them over to another hospital bed, but most of the time, we go straight from our bed into CAT scan, and then we'll give report to the neuro team taking care of them. We'll give report to the physician, to the nurses. We'll try to give them a really accurate description of what the patient called with or what the family called with, how long the symptoms have been going on, when they started, their last known normal, and any interventions we made on our way to the hospital. And once we do all that, we pretty much turn care over to the emergency team, and they go from there. So I know that was a quick kind of 1, 2, 3 of what we do in EMS. Does anybody have any questions or comments? No? All right, thank you.
Thank you, Officer Crawford. Our next speaker will be up at 10:45, talking to us about stroke risk factors. All right, guys, it's time for our next speaker. It's going to be Dr. Himanshu Chokhawala. Dr. Chokhawala is the co-medical director for the only comprehensive stroke center in the region, and he's our vascular neurologist as well as a neuroendovascular surgeon at LSU Ochsner. And he's played a very big role in making this event happen. So I welcome Dr. Chokhawala to give us our next talk.
Right, I think we'll talk about the stroke risk factors. I think so. I usually talk about this with my patients, be it whether it was a stroke or something closer to a stroke, is the risk factors which help us in improving our day-to-day life activities and living a healthy life. So mainly the stroke risk factors are divided into modifiable and non-modifiable. Modifiable are the ones that we focus, non-modifiable we are not going to be able to do much about it. So we'll go one after the other, and they affect us just not for the brain or stroke, for heart attack and any other medical problems that we might face. The first one is high blood pressure, and this graph really signifies how we, as soon as our blood pressure raises above 130, at the top number, and the bottom number above 80, the risk factor for stroke increases, and it increases dramatically after if it's above 180 consistently. So stroke, your goal for blood pressure should be below 130 over 80. Blood sugar or diabetes, you monitor with HbA1c. So HbA1c is monitored. You monitor your blood sugar over 90 days, and it is used to diagnose diabetes and pre-diabetes. That's one of the very important risk factors for stroke. A little difficult to control also. The ranges that we have, when you control your diabetes with A1C less than 5.7, and if you diagnose diabetes when the A1C rises up above 6.5. Another important one is smoking. Cigarettes, very prevalent, especially in our region. Any cigarette smoking, anything more than one cigarette a day is a risk factor. So there's no negotiation, is cutting down and say 5 cigarettes a day would help. No cigarette is good. And the other risk factor is high cholesterol. Especially our diet here, Louisiana diet has high greasy, salty food, and that results into high cholesterol. So controlling that is very important and one of the important cardiovascular risk factors. The other is sedentary lifestyle. What we have seen within stroke is if we have sedentary lifestyle where we do not move around for more than 4 hours in a day, mainly our desk work, which being on computers has resulted into sedentary lifestyle, increases your risk immensely for stroke. Obesity, and if you see the other risk factors is our diet, sedentary lifestyle, high cholesterol also built into obesity. So everything builds in, and obesity with BMIs, body mass index, is more than 25 increases your risk. So your goal should be to have a lean body mass with weight of less than 25 kilo per meter of height. And the other risk factor is drug use like cocaine, amphetamine increases, and even marijuana increases your risk for stroke. The last one, which is very important and I think very commonly missed, is obstructive sleep apnea. As we control the other risk factors, it also helps controlling sleep apnea. And but this is one of the risk factors which increases our risk for not only just stroke, heart attack, high blood pressure, diabetes, depression. Dr. Asghar in a while is going to talk about sleep apnea a little bit more in detail. But this one is also one of the very important risk factors that we need to identify as soon as possible for prevention of stroke and also for treatment of stroke. Okay, that's it.
Our next speaker is going to be Dr. Sheila Asghar at 11 o'clock. Hey guys, so we are ready for our next speaker. It's going to be Dr. Sheila Asghar. She is the Assistant Professor of Neurology and Pediatric Neurology at LSU Ochsner, and she's going to be giving us our next talk on sleep apnea and stroke.
Hello, everybody. Welcome. And I think the talk that I'm going to do right now is very important and relevant. So try and listen, and I hope it will be useful. Okay, so this is what I call the perfect storm, a combination of sleep apnea and stroke. Right. I put this in. I don't have any disclosures. So laugh and the world laughs with you, snore and you sleep alone, except for your dog who might tolerate your snoring. And of course, I have no disclosures this morning. So your tongue can be your worst enemy. And this is the main cause for obstructive sleep apnea, when you have a large tongue that obstructs the airway. Am I too loud? Is it too loud? And so when you're sleeping at night, your tongue can go back, obstruct your airway, and cause obstructive sleep apnea. And what does it look like? Well, you have these episodes where you stop breathing, and that's called the apneic episode. And if you do this many times at night, then of course it's not going to help. It's going to fragment your sleep. All right. So anyway, if you have a big tongue, that's an issue, and that can cause obstructive sleep apnea. In children, remember, it's the tonsils that can obstruct the airway. So, what is the diagnostic criteria for obstructive sleep apnea? How do we know when people have obstructive sleep apnea? So either you can have symptoms like daytime sleepiness, not sleeping well at night, or even fatigue, or you can have a problem with gasping or choking when you wake up in the middle of the night. Your bed partner could be saying, well, he's snoring a lot. They might complain of that. Or the patient has another problem such as hypertension, mood disorder, coronary artery disease, and even stroke. If you get a sleep study and you have more than 5 obstructive events per hour, then you do make a diagnosis of obstructive sleep apnea. Now, if you have more than 15, then definitely you make the diagnosis of obstructive sleep apnea. All right, what is the situation for obstructive sleep apnea? It is much more common than we think, because 24% of men have an AHI or an obstructive index more than 5. And if you have an AHI more than 5 and daytime sleepiness, that's prevalent as well. So this is something that's very undiagnosed, and many people go through their lives not knowing that they have obstructive sleep apnea. So this is something that needs to be taken care of very seriously. All right, I put this slide because obstructive sleep apnea affects every single organ in your body, everything, including puts you at risk for stroke, congestive heart failure, hypertension, sudden death, heart disease, mood disturbances, and you know, it costs our medical costs more than 4.3 billion a year. But if you treat it, the costs come down to 200,000. So that's something to keep in mind. And that graph just shows that there is a high prevalence of obstructive sleep apnea with stroke. All right. We are going to look a little bit at stroke, and I know that we've had prior speakers who talked a little bit about this, so I'm not going to go into it too much. Just you have to remember that stroke is the 5th cause of death and a leading cause of disability in the States. And the problem is the consequences that happens when you have a stroke, specifically neurological defects, meaning you have weakness and you have to undergo rehabilitation. So OSA and stroke, unfortunately, they make what we call the perfect storm. Because if you have both things together, your outcome is going to be much worse. So OSA is an independent stroke risk factor. So many people with OSA can experience stroke-like symptoms and can have stroke at night, things that they may not be aware of. And that is just the mechanism of how it happens. OSA is also very common following stroke. So that's something we see in the hospital, that after stroke, patients should be screened for obstructive sleep apnea, and a lot of times that does not happen. So what can we do about this? We can use early screening tests for the diagnosis of obstructive sleep apnea. We can use the stop band questionnaire, home sleep study tests, or a polysomnogram. especially post-stroke, we can do screening. The test that we use, the screening test, and we have handouts at the back if you need to look at it, is the stop bank questionnaire. And it's very easy, and I would challenge you guys to do it on yourself as we go through it. So, has anyone observed you stopping breathing, choking, or gasping during sleep? And if the answer is yes, you've scored a point. Is your blood pressure high, or are you being treated for high blood pressure? If the answer is yes, you score a 2. If your body mass index is more than 35 kilogram per meter squared, you score another point. If your age is more than 50 years, you score another point as well. And if your neck circumference for men, if it's more than 17, you're at risk for obstructive sleep apnea. In women, if your neck circumference is more than 15 or 16, that puts you at risk for obstructive sleep apnea. And unfortunately, if you're a male, you're already at risk for obstructive sleep apnea. So if you calculate the points and you get a 6 or 8, that means you're at a high risk for obstructive sleep apnea. And this is something easy, anyone can do it. And if you think you're at risk for obstructive sleep apnea, this is something you need to pursue. Talk to your PCP, get a sleep study done, or even a home sleep study. Now, what's a sleep study? So a sleep study or a polysomnogram is, I think, one of the most comprehensive tests that we have. So what happens is at night you come in and you have a sleep technician that greets you. The sleep technicians are very well trained. So initially what they do is they put leads on your head, EEG leads, because they need to look at what stage of sleep you're in when you're sleeping through the night. The second thing that they do is they put nasal probes in your nose to look at nasal flow inside your nose. You have pulse oximeter to know how much oxygen you are having throughout the night. EKG leads to look at heart rate, and then 2 belts, an abdominal and the thoracic belt, to see how much air you're taking in. So overall, this overnight study gives you a lot of information. It gives you information about your oxygen status, about your heart rate, how much air you're actually taking in, and it also tells you if you have obstructive sleep apnea. Not only that, a sleep study can become a treatment modality, because at night, if you're having a lot of obstructive events, the sleep technician can start the treatment. And what is the treatment? CPAP. CPAP is the treatment. So this is what they can do for the rest of the night. They can actually find a mask that you feel comfortable with, and then do the rest of the sleep study with the mask and make sure the obstructive events are taken care of. So that's the full sleep study that we have. Now, CPAP has proven to be very effective. That is if you use your CPAP every night, because it reduces risk factors, decreases blood pressure, sympathetic activity, and it reduces mortality in stroke and OSA. So this is something that's very important. This is something you need to do, especially if you are a person at risk for obstructive sleep apnea needing a CPAP. Now, what kind of CPAPs do we have? We have all different kinds. Why? Because we want our patients to use their CPAPs at night. Now, one thing you have to remember is you need to figure out whether your patient breathes through their nose or their mouth. So you want to choose a mask depending on that. If you're a nose breather, then you have these models that just fit over the nose. If you breathe through the mouth, then you have those, the last 2 ones, that just fit over your mouth. So you want to find the one that suits your patient the best, or a combination of 2 that looks like a Darth Vader type of mask, because it covers your nose and your mouth, and you have forehead straps as well. So this is what we do, because insurance companies, if you don't use the CPAP machine for more than 4 hours every night, 80% of the time, they'll take away the machine. So we really want to make sure that you love your machine. Your machine is the most important thing apart from your wife or your husband, right? You want your CPAP machine. Okay, that's all I have. This is our sleep lab. We have a very nice sleep lab. It's state of the art. It's nice and comfortable. It's like a hotel. I don't mind sleeping there myself. There's a big TV and a nice bed. And so I want to thank you for your attention. And I want to thank Dr. Chernyshев because a lot of material that I use came from his presentation. So thank you so much. If you have any questions about CPAP or obstructive sleep apnea, who do you need to see at LSU Ochsner, please ask me. I can help you with that. Thank you.
Thank you so much, Dr. Asghar. Our next talk is going to be at 11:15, and it's going to be Allison Mayfield.
Our next speaker is going to be a live demonstration from our Kid Fit from the YMCA. This is Miss Allison Mayfield. Welcome to the podium.
Well, okay. Hello, my name is Allison Mayfield, and I am one of the Kid Fit instructors at the YMCA at this one right here. Just a little information about me. I have been into kids fitness for a long time. I have been a teacher for 22 years, and the physical education and adaptive physical education working with special needs students. So I'm all about kids fitness. I also coach cross-country teams and work with a running program in the summer. So I am all about getting kids moving. We all know that kids fitness is important and how we just need them up and moving, not only for their fitness, for their mentality, for their health, all aspects of their life, and it helps them better in school also. So at Kid Fit at the Y, it's an hour-long class offered several days during the week. And not only gets your kids moving, but the adult can go work out while their kid is moving around and getting some physical fitness. So we just do several different games. It's up to the instructor for that evening. I like to do a lot of games that involve physical fitness. So, what kids want to participate today? Come on over here. I have a few games with us today. You know what? Can we get in a circle? Right here? Who knows how to make a circle? Okay, get over here. Let's spread out a little bit. Jordan, you want to come? Okay. Well, do you want to come join us? Okay. Oh, yay. A lot of my games in my Kid Fit class, like I said, we do exercises to help us moving around, right? My kids in my class get lucky because I'm in the PE field, so I got a lot of fun games. But one of my games we play at my school is just with a beach ball, okay? Let's take one step back. I don't know any of your names, though. So what I usually do is I say the name, they catch the ball. Whatever color they land on, they get to pick the exercise. And everyone in the circle does the exercise. Since I do know one person in this circle, I'm gonna throw it to her first. Her name is Jordan. She's to my left. Harper, sorry. I know, I'm calling her by her mama's name. So, she's gonna catch it. And whatever color one of her fingers land on, she's gonna pick that exercise, and we're all gonna do it. Think we can do that? All right. Ten honeys. I'll hold it for you. Okay, does everybody know how to do a honey? Okay, I don't want to knock this earpiece off of me. I'm gonna try to do it with you, okay? Ready? Honeys. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Freeze. Good job. All right. Since I don't know your names, I might just call you by your shirt color, okay? The cute little one in the butterfly dress. Ready? Oh, good catch. What exercise? She landed on yellow, I think. 5 squats. Does everybody know how to do a squat? Ready? 1, 2, 3, 4, 5. It's almost like you're trying to sit down in a chair, right? All right, we're gonna throw it to the only little boy in the circle. Ready? And the purple and white striped shirt. Ready? Catch. What did he land on? He landed on green. What was it? Butterfly sit. Who knows how to sit down and do a butterfly stretch? You're all doing it right. Good job. You know what we do at school? We kind of flap our wings and we fly away for 10 seconds. Ready? 1, 2, 3. Your legs. 4, 5, 6, 7, 8, 9, 10. Doesn't that feel so good to stretch your hips like that? Okay, everybody stand up. I want to give everybody a turn and then we'll do another activity if we have time. The black bow. Ready? Catch. She landed on green too. What exercise? 10 sit-ups. Who thinks they can do 10 sit-ups? Ready? Everybody get down. Everybody knows how to do a sit-up, or sometimes they say curl-ups. Bend your knees, and go up. 1, 2. Oh, look at those good sit-ups. 3, 4, 5, 6, 7, 8, 9, 10. Oh, way to work your core. Do you know that your core helps you in all activities of life? Even just walking around, when you start getting slouchy, if you have a strong core, that's very good. All right, is that a tiger on your shirt? Or a unicorn? Oh, okay, ready, catch. Ooh, she landed on orange. 5 push-ups, who knows how to do push-ups? What? Okay, I'm gonna go with y'all and count. Ready, bend your elbows. 1, 2, 3, 4, 5. Woo, somebody's been teaching y'all pretty good. There you go. Winnie the Pooh. Ready, catch. She's gonna do yellow. Try to do one we haven't done. 10 arm circles, that's pretty easy. Ready? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Good job. We have one more that hasn't gone in the circle. Was it Ava? Asa? Asa. Aislin. That's interesting. I like it. Ready? Catch. Blue. 2 what? Oh, she got a good one. She got 2 running laps. Behind me, we're gonna make 2 laps. Ready, go. Oh, almost on the finish of their first one. There goes one. Oh, almost completely done. And 2. Good job, good job. All right. So other times when you come to Kid Fit, sometimes I have these little dice we roll around in the circle. Sometimes I do baton relays. Have you ever done a baton relay where you race back and forth? Sometimes we play good old dodgeball and things like that kids like to play, but that's also getting you to move around, right? Right. How much longer do we have in here? 6 minutes. So, we don't have enough room to really do this, I don't think, in here. But what we can do to keep us moving, and I don't want to step on that cord, let's have 1, 2, 3, 4. Line up on this yellow line, facing this way. You're going to be the leader. And behind me, you two can get behind me. There we go. So what we're going to do, I'm going to call out a locomotor skill. Do you know what a locomotor skill is? Hopping, skipping, galloping. We do this a lot in Kid Fit too. I got to test you and make sure you know that's what they are. We're going to go all the way down to this blue line, and then you're going to sprint back and get behind the last person in line. I'm going to go too, so we can make it even. All right? All right, we're going to hop on one foot. Ready, go. 1 foot. And sprint back. All right, hop on 1 foot. Keep going. Oops, she went. Wait till the next person comes back. I'm sorry, I should have told you. Go. Go. This time, we're gonna face this wall, and we're gonna shuffle. Do you know how to shuffle? Like this. Go. And sprint back. Go. Next person ready, go. Ready, go. All right, the next thing we're gonna do is skip. Does everyone know how to skip? I'm gonna see, let's go. And sprint back. Go. Next person. Good job. And go. Now, the very next one we're gonna do is a little tricky. It's gonna work total body. I'm gonna even try to do it. Let's see if I can keep this on my ear. Who knows how to crab walk? Don't do this. That's what a lot of kids will say it is. How do you do a crab walk? You don't know? What? I'm gonna show you. Ready? Let's go. And then, sprint back. Ready, go. You're working everything here, go. You're working your arms, your legs, your core. Good job, girls. Ready, go. Almost, you're almost there. And the last one we're gonna do is galloping. Ready? I know everybody knows how to gallop. Go. And sprint back. Go. Go. Ready, go. And back. Good job. Okay, let's get in one more circle. I like to end class with a little stretching, all right? Because after you're moving around in any type of exercise, it's always best. I'm having trouble with this. It's always best to stretch, okay? I'm going to pick someone in this class right here that we have going on to give me a stretch to do. Oh, that's a good one. Let's bring it up, too. Harper, can you give us a stretch? I like for these kids to have their creative thinking brain on. There we go. Oh, give us a stretch to do. Oh, touch your toes. Who can touch your toes? Oh, that's a good one. There's a lot of people that can't touch their toes, so always, you know what? You should every day try to touch those toes. Give us a stretch. Oh, that's a good one too. Stretch your back. Oh, I can't go that far back. Ooh, woo. Give us a stretch. Oh, that's a good one too. Okay, this is gonna be our last stretch. Let's hold it for 10. Everybody count. Ready? 1, 3, 4, 5, 6, 7, 8, 9, 10. Y'all did a great job today. Good job. All right, you know what? Come to one of the Kid Fit classes at the Y and you can do that almost every day of the week. Look on the schedule. Y'all did a great job. Thank you for helping. Thank you. Enjoy the rest of your day. Good job. You did a good job. Good job. Good job. You're welcome. Good job. Thank y'all. Thank y'all so much.
Well, I'm back again, and it's very hard to top that activity that we just had. So we'll try and go through this fairly quickly because it is very important, pediatric stroke, especially for all you all who have kids. This is something because kids can get strokes, just like adults. All right. I have no disclosures to declare. So I think the idea of talking today is to show you that stroke is different in children. So the symptoms and signs that children have are going to be different. To be able to name some warning signs of stroke in children, and to know that the treatment may be different in children as well. So remember, children are not little adults. They're different. So therefore, the diagnosis, treatment, and management has to be different. Current situation, unfortunately, a lot of pediatric stroke goes underdiagnosed. And it is there, and we haven't even included neonates because guess what? Little bitty babies can also have strokes. It's about 1 to 2 per 100,000. The mortality is around 3%. However, long-term neurological impact is almost 70%. So when children get strokes, what happens is they have to go through rehabilitation as well. All right, the problems with pediatric stroke are many. First of all, we're not able to recognize, and so it gets missed. And what happens is time equal brain. So if you're taking that long to diagnose a stroke in a pediatric patient, you've lost time, you've lost brain. Because normally, it takes at least 15 to 24 hours before you have the diagnosis, because many small centers do not have an MRI. They can't do an MRI and make a diagnosis in that child. And so what happens is then it gets missed, and we don't have enough stroke centers. At LSU Ochsner, we're able to do that. We're able to diagnose it, but in other smaller hospitals, that may not be the case. Treatment is a problem for children who have strokes because we don't have standardization of care, and TPA that we use commonly in adults, it's not FDA approved in children. So that restricts the number of treatments that are possible for children with stroke. Risk factors are many, but I want you to focus on the ones that are important and are not noticeable in children. If you have kids with migraine over time, sepsis, acidosis, dehydration, that can put them at risk for stroke, especially in little bitty babies. Remember that 20% is idiopathic, meaning that no known cause. Also remember, unvaccinated children are at higher risk, so you want to make sure your children are vaccinated. How do children present with stroke? It's different, so they may not have your typical signs of weakness. They may present with irritability, altered mental status. They may present with seizures. Many children, first-time seizure could mean that they have had a stroke. So that's very important in children. Don't want to walk, not able to speak anymore. Those are some symptoms that children can have. Now, the other reason why stroke is not diagnosed as frequently in children is because the stroke symptoms look like other things. And what can they look like? They can look like Todd's paralysis. What is Todd's paralysis? Every time you have a seizure, you may have weakness of an arm. That's called Todd's paralysis. You might have hypoglycemia, low sugar, and because of low sugar, you may have weakness. Complex migraines can look like stroke. A child with a brain tumor can have symptoms that look like stroke, but it's actually the brain tumor. So all these other things can look like stroke. The other biggest one is psychogenic. So we see that a lot in teenagers, and they may have psychogenic symptoms and not necessarily a stroke. How do we diagnose? Very easy. There's a NIH SS scale, and I put in the link if you are interested and you would like to look at that. So you can use that, and it's easy to use, and you can diagnose if a child has a stroke. Treatment, remember, it's not FDA approved, but some big centers like Houston, New Orleans that have standardization of care can give alteplase or TPA and mechanical thrombectomy. I think there's a table over there that shows you what we mean by thrombectomy. All right, I want to finish up with a story. So I have been following this child. I was practicing in Hershey before coming here, and I took care of this little kiddo. I got mom's permission to share the story. So she presented at 5 days of age. So she was a small little bitty girl, and she presented with twitching of her left arm as well as a clicking noise with her tongue. And this started at about 4 a.m. Her eyes were also deviating to the right side, or was it the left? To the left. And it started at 4 a.m. and it continued till 11:30 a.m. They went to a local hospital in Pennsylvania, in Hershey, and they said, oh, she's having a seizure. So they gave her a seizure medicine, and at that time she was transferred to the big children's hospital in Hershey at Penn State. They did an MRI, and you know what? They saw a big stroke in the basal ganglia. That was causing her seizures. And so they treated her, they started her on a seizure medicine called phenobarbital. But day 3, what happened is there was swelling of the brain. Usually when you have stroke, within 24 hours, you can expect some swelling. And they thought that they would have to go in surgically, but I think it's a miracle. This child is like a miracle baby. On day 4, she improved. Seizures stopped, swelling went down, and she could actually feed. And so she was discharged 6 days later. She was on seizure medicine for 1.5 years, did very well. A repeat MRI at 9 months showed that the lesion or the area where the brain had died had actually decreased. So this was good. She was in physical and occupational therapy for about 6 months, did very well. And you know what? She never became developmentally behind. In fact, she was 3 to 6 months ahead of time. And I think this is because of quick action, and they quickly found a diagnosis. And also, I think, has to do a lot of, support and love from the family. So this is what she looks like, and I've kept in touch with the family. This is just a summary, and we went through it, but this is specifically for children. These are some of the things that we need to keep our eyes on children. And as I said, they may not have all these symptoms. They may have different symptoms like severe headache, sudden weakness, trouble seeing, difficulty walking. Remember, there's lack of awareness, so usually this may be misdiagnosed. And children can have previously identified risk factors. And remember that treatment is not FDA approved for use in children. That's it. Thank you guys for your attention.
Thank you, Dr. Asghar. Our next speaker is going to be at 11:45. And please make sure your booth's tracking cards are filled out and turned in for the prize drawing basket, which will be at 1:30 p.m.
Hi. Hi, my name is Aislin Tomlinson.
And I'm Harper Walton, and we're from Eden Gardens Magnet.
Okay, so today we're going to be making the kale tonic. So it has 3 leaves kale, 2 small to medium Fuji apples, 2 cups water, 1 English cucumber, the juice of half of a lemon, and the serving size is 1 serving. The calories is 150. Lots of protein and fiber. Okay. So first you got to wash and chop apples and cucumbers. That was loud. And then you remove and discard stems from kale leaves. Into there. Oh, into the blender. Okay. Okay. Yeah, okay. So just pull down. Okay. So we're gonna pour this all into this high-speed blender here. Oh, okay. There we go. So we got the apples and the cucumbers. Okay. Okay, then we're gonna put the lid on here. And then we are going to, shred it. So, is it on? It's on, okay. Okay, so first we're gonna liquefy. Oh no! Okay. Okay, so it's got, the serving size is 1 serving. There are 150 calories. It has 30 grams of carbohydrates. It has 1 gram of protein and 2 grams of fiber and 30 grams of sugar. Okay, that should be good enough, as you can see. Okay, so now we got this, and we're going to pour this into our fine mesh strainer here. We go. Okay, and then we're going to start juicing it with this spatula. So we just push down, get all that juice stuff out. Oh, lemon now. Okay, now put the lemon in there like that. Okay, put it over here. Squeeze that in. Oh, in the bowl. Sorry. Okay, squeeze into the bowl. Hey. Other half? Both halves? Okay, we forgot the lemons. Okay, so we're just squeezing the lemon juice into the bowl now. Yep, get it nice. Okay, we're good. And now we're just going to continue squeezing the juice. Oh, that's good. Out of this stuff. You can also bake this extra kale leaves and Fuji apples into bread. Yeah, so my friend did that and it was good. Okay. Where do we put this? Okay, so we're just gonna push down really hard. And so with no added sugar, this vegetable-packed juice is full of vitamins, antibiotics, that supports a healthy immune system. It has natural sweetness that is both delicious and refreshing. Just smile. Okay, so we're gonna put this into an ice-cold pitcher. Pour it in and then you're gonna hand it out. No. Yes.
Start handing those out. I'll help you. You can talk about.
So we have some optional add-ins to make it sweetener, and this is super good. So you can do 1 to 2 inches cubes of peeled ginger, 1 to 2 inches of peeled turmeric, spinach, or celery, and it also makes it more healthy, but it's really good. And you guys can come up and get a sample. It's really good, and I recommend. And is there not enough? I will taste this. Come on up. It's really good.
Our next presentation is going to be a healthy cooking demonstration from Flames Mediterranean Restaurant. We welcome Chef Sia in about 3 minutes.
Hello, everyone. My name is Sia, and I'm from Flames, right down the street. We're just going to practice a couple of the healthy and summer food, which is grilling. And today I just brought seafood, which is shrimp, and chicken. On the side, I have a grilled veggie. Grilled veggie is very healthy and is, as you see, zucchini, pepper, onion, squash, and that's about it. What you do, you just put a little water on it and then put like your seasoning, which is mostly we use Tony's, little garlic, salt and pepper. And then you grill it to your satisfaction. And then on the end, for serving it, we normally put balsamic vinaigrette, which, as you know about the stroke things, vinaigrette helps the vein to deliver the blood much easier. So it's help. And we have some prepared, which is going to be a Greek salad, which is very healthy. It's combined with the lettuce, tomato, cucumber, onion, olive, and also feta cheese. And we serve it for the summertime. It's healthy and quiet. Another thing is the shrimp. Very easy to make it. Very, very easy. You clean your shrimp, and then before you put them on the grill, for simple trick, marinate them in Italian dressing, and then put some Tony's, garlic, and you can have lemon pepper and put them on the grill, and it comes up just like this. And again, you can serve it with the same salads, and I have a grilled veggie in the middle, as you see, which with balsamic. They are very healthy. They have less than 500-600 calories, and it's awesome for the summer times. We have a lot more recipe. If y'all come to the shop, I'll be delighted to share with y'all. We have a seasonal soup for the winter time and the chicken salad for the summertime. So here it goes. You can go online and check on the Flames. We got all variety of food. If y'all have any question, y'all feel free to call me at any time. I'll be delighted to share with y'all. Enjoy it. And I got some grilled veggie if anybody wants to taste of it.
Thank you so much, Mr. Sia. Flames Mediterranean Restaurant is just located just down the road in the Ashley Ridge Center. They offer a passion for market-fresh ingredients, honest cooking, and enjoyable atmosphere. Mr. Sia is always there and always pleasant, and he's so fun to interact with, so I'm so thankful that he came to join us today. And please go visit him at Flames anytime. He'd love to have you. So thank you, Mr. Sia.
All right, guys, we're going to have one of Ochsner's very own speech language pathologists and speech pathology supervisor, Ms. Stacie Odom, talking to us about communication, thinking, and swallowing disorders after stroke. So please welcome her.
Thank you. Hi. I have to make sure I can use the clicker. You can't hear me? All right. So I'm here to talk about speaking and swallowing after stroke. But first I have to learn to use the clicker. Which one did my hit? Okay,
I think it's
all right. Okay, thank you. All right, so it wasn't me, it was the clicker. So I'm here to talk about communication, thinking, and swallowing after stroke. I'm one of the speech pathology team at Ochsner LSU, and we treat patients who have had stroke on both the inpatient and outpatient basis. So your brain is what controls your thinking, your communicating, and your swallowing. And each of these skills involves a certain part of the brain. And so your deficits in speaking or communicating, thinking, or swallowing have a lot to do with what part of the brain is impacted by your stroke and how much of your brain is impacted by your stroke. The first thing I'm going to talk about is language. And language is how we communicate information, how we express information, how we deliver messages to people. And communication and language can be done verbally, it can be done through writing, and it also could be done through gestures or sign. And so people who have had stroke who have difficulty with language may have difficulty expressing themselves, or they may have difficulty understanding, and that can be expression through words or expression through writing. understanding what they hear or understanding what they read. And so you may have people who, you may hear the term aphasia, and patients will have expressive or receptive aphasia depending on what part of the brain is involved in their stroke. The next thing we're going to talk about is speech. And so speech is just one way to communicate. And for our patients who've had strokes, you may notice that they have slurred speech because they have weakness in their mouth muscles, the face, the lips, the tongue, any of the muscles used to produce speech can be weak, and that can cause dysarthria, which is a muscle weakness, slurring of speech. We also may have a disorder called apraxia, which has to do more with the messages that come from the brain to the muscles. The muscles are intact, so a patient can smile, they can move their muscles, but they can't do it on demand when they need to make words. Patients with stroke may also have difficulty thinking, and there's a lot of areas of thinking that are involved in the different aspects of our brain function. Memory is one deficit. It's the one you hear about the most, but also people have difficulty keeping up with time, difficulty learning new things, difficulty solving daily problems for living, and those are things that we can assess and treat as a speech-language pathologist. So swallowing is probably the first thing that we address when we see a patient in the hospital who's had a stroke. And this is so important that there are different levels to swallowing evaluation. So someone who comes in who's had a stroke will be first screened by a nurse to detect any possible swallowing difficulties, and then they will be seen by a speech therapist to look at all aspects of the swallow. And swallowing deficits can occur orally, so that you have difficulty chewing, difficulty moving food around in your mouth, or they could occur when you actually go to swallow the food and you have weakness in the muscles in your throat. Some signs of difficulty chewing or swallowing that you might see if you or a loved one or yourself has had a stroke, if you have difficulty moving food around in your mouth, you have difficulty moving food from the front of your mouth to the back of your mouth, you have a wet voice quality after you eat, you have coughing, you have choking, you have pocketing of food in one side or the other. Sometimes people will say they feel like their food is getting stuck in their throat. So all of those are signs that we need to further address swallowing with a formal evaluation and see if we can help those issues. So a speech-language pathologist is the professional that will evaluate and treat communication, thinking, and swallowing problems. In order to become a speech pathologist, you have to have a master's degree, and then you have to complete a clinical fellowship, and then you can become licensed in the state where you practice, and also we have to be certified by the American Speech, Language, and Hearing Association. Some of the things that speech therapists might do to address problems after a stroke are to do swallowing and oral motor exercises for speech and swallowing. We may modify diets to make things safer for someone to swallow. We may teach someone maneuvers to move their head in a certain way or put their head in a certain position to swallow. Changing foods to different textures, also working on different communication strategies or compensatory strategies for thinking as well. So if you have a need for a speech pathologist, you or a loved one have a need for a speech pathologist, they work in all different levels of care. We have inpatient acute care, outpatient, long-term acute care, inpatient rehab, home health. You can find speech pathologists in all levels of care. At Ochsner, we see patients on the inpatient acute care side of things, and we also see patients on the outpatient side of things. And that's about it. Does anybody have any questions? I went too fast. Thank you so much.
Thank you so much, Stacie. Wonderful presentation. That was a really good segue from our healthy cooking demonstrations. At 12:45, so in about 10 minutes, Dr. Chokhawala will be back to the podium to talk to us about stroke treatments. Thank you.
Right, so we went over all the stroke risk factors and how to identify stroke so that we can appropriately treat them. As we know that, we went over the BEFAST for identifying stroke emergently, and then the stroke can be treated if the patients come in within the window emergently, and there will be, of course, be post-stroke management for all the risk factors. So for the emergent treatment, patient has presenting symptom of one of those 5, BEFAST, balance, again, eyes, face drooping, arm weakness, slurring of speech, right? Time to call 911. So first important is to identify which EMS would identify those and stabilize the patient, stabilize the airway, breathing, and circulation. What's important is not to give aspirin unless we have a CAT scan. This is something which, someone has a blockage in the heart and they get the aspirin, but it's not the same for the brain. If you have weakness, it could be from the bleeding or from a blocked vessel. So bleeding can make, aspirin can make the bleeding worse. So you don't give aspirin unless we have a CAT scan done in the emergency. If the patient shows up within 4.5 hours of their last normal, then we can give them clot-busting medication called TPA. And about 1 in 4 to 1 in 7 patients can live an independent lifestyle if they come within 4.5 hours and get the clot-busting medication. So it's one of the very important treatment in stroke. Also, if they have a large blood vessel block, then they can get the clot removal procedure. And these are actually four slides which shows the blocked vessel which we took out. It's a little difficult to see here, but the clot was removed and they started getting flow to that side of the brain. So once they arrive and they are candidate for the stroke, we can get the patient to the hospital with gradual treating their blood pressure. We don't necessarily treat them and drop their blood pressure to normal levels, but the long-term goal for the stroke, blood pressure should be less than 130 top number. Also, the blood glucose, we don't drop them too low to normal levels. We're not aiming for normal levels while they are in the hospital. But for long-term, hemoglobin A1C needs to be close to 7. And then blood thinners. Depending on how the patient's CAT scan looks, patient can be on aspirin or Plavix or Brilinta. There are different blood thinners. The stronger blood thinner that you might have heard of is Eliquis or Xarelto, can be started if the patient is in atrial fibrillation. Then rehabilitation is, of course, very important piece. We just heard about, so patients should get physical therapy, occupational therapy while they are in the hospital, and also if they meet the criteria, then they can be transferred to an inpatient rehab where they can get further about 2 to 3 hours of rehab facility. There you go. we have inpatient rehab here today. And they benefit a whole lot if they can go to inpatient rehab rather than going home. Also, speech therapy, you heard Stacie Odom. talk about speech therapy, which is important if they have some slurring of speech, difficulty swallowing food, or even have difficulty with understanding the language. The other important treatment is maintaining your blood cholesterol levels. Diet, and we spoke a lot about diet today. Also, what we need to know is to start statins, atorvastatin or rosuvastatin. We are reaching our goal is to reach the bad cholesterol, which is LDL, which needs to be less than 70. Then the diet that is encouraged, like we saw, is Mediterranean diet that helps with obesity as well as controlling your blood pressure and cholesterol. The diet that's encouraged is Mediterranean diet, which has more greens and salads, fresh fruits. More, if on the protein side, have baked and grilled chicken and fish. Try to avoid pork and beef. Right, and of course exercise. While we are at YMCA, exercise is important. About 30 minutes every 3 to 5 days in a week. And sedentary lifestyle is where you have more than 4 hours of sedentary lifestyle. So try to avoid that and be moving around, exercising. Avoid smoking. Avoid illicit street drugs. Of course, no cigarette. 0 cigarette is what you need. There's no negotiation on that part. And alcohol in moderation. All right.
Thank you so much, Dr. Chokhawala. In just a few minutes, we're going to have some occupational therapists join us from Encompass to talk to us about post-stroke rehab. Thank you. Okay, I'm going to go ahead and let them get started a few minutes early. This is Miss Callie Rash and Miss Courtney White with Encompass Rehab.
May I have your attention, please? This is your captain speaking. My name is Callie.
And I'm Courtney.
And this is A Flight to Recovery.
To start today's presentation, we're going to go over some quick facts about a stroke diagnosis. So up first, we have some risk factors that can lead to a stroke. There are controllable and uncontrollable factors. So some controllable factors include high blood pressure, diabetes, and physical inactivity, and also AFib. Some uncontrollable factors would be age, so the older you are, the more likely you are to have a stroke. Race, gender, women are actually more likely to have a stroke than men. And then also if you've had a prior stroke, a TIA, or a heart attack.
So now we're going to talk about the signs and symptoms, which there was a presentation earlier regarding this, but in case you weren't here for it, we're going to go over the acronym of BEFAST. So B stands for balance, I is for eyesight, F is for face drooping, A is for arm weakness, S is for speech difficulty, and T is for time to call 911. It is really important if you're experiencing any of these to call 911 because you can get to the hospital and have TPA, or the clot buster, which is for ischemic strokes, which can actually reverse your stroke.
All right, so if you've had a stroke, some of the effects that you can have are physically, you might experience weakness on one side. Emotionally, you might experience depression or anxiety. Cognitively, you might have some troubles with your memory. Communication, you can have aphasia. Swallowing, you may need to be on a modified diet or even a PEG tube. And then with your vision, you can have double vision, which can lead to dizziness.
All right, let's talk about our itinerary for today. We are going to start with briefly on each therapy setting that a stroke survivor could go through during their recovery journey. These include acute care, inpatient rehab, home health, and outpatient rehab.
All right, so booking your ticket. Booking your ticket is like going to the hospital. It is the first step in your flight to recovery. This is when you decide to seek medical attention and you need to get to the hospital as fast as possible.
So let's review the types of stroke. You have ischemic, which is whenever the blood flow to the brain becomes blocked. This is actually 87% of all strokes. You have hemorrhagic, which is bleeding in the brain, which the most common cause is high blood pressure. You have transient ischemic strokes, brainstem strokes, and your cryptogenic strokes.
So once you are at acute care, this is like going through security at the airport. It can be hectic and stressful, but it is an essential step so that you can have a successful trip. This is where your journey truly begins. You will receive your diagnosis and begin therapy. And while the therapy is very minimal, it is preparing you for the next step.
Once you have been cleared by your medical staff in acute care, the next step is choosing your inpatient rehab. Inpatient rehab is the best option as you get 3 hours of therapy 5 days a week. A great source to compare rehabs in your city is medicare.gov/care to compare, where you can compare inpatient rehabs in various categories. Examples of this improvement is self-care and mobility. As you can see from the chart, Encompass currently ranks #1 in the city of Shreveport in both of these categories. This knowledge is open to the public, so please, whenever you're choosing your inpatient rehab, take a look at this.
All right, so what is inpatient rehab? While in inpatient rehab, the patient will receive intense rehab services while under the care of various medical professionals. At Encompass, we offer a customized care program for patients who have experienced a stroke. They will receive 3 hours of therapy a day, 5 days a week. And inpatient rehab is the only setting that offers this amount of intense therapy. We are also in the process of becoming a stroke accredited hospital through the Joint Commission, and we will be the only inpatient rehab in Shreveport to offer this.
All right, let's meet your flight crew. So while you're at inpatient rehab, we offer lots of services. You've got your physician specialist, your neurologist, your nursing staff, respiratory, pharmacy, case managers, our liaisons, dietary, and therapy staff.
First up in your flight crew, we have the pilots and co-pilots. These are going to be your rehab doctors and your neurologists. So they will check in on the patient daily, face-to-face, and will monitor the charts for any changes. Your nursing staff will provide medications daily, assist with bowel and bladder programs, and also keep a close eye on the patient for any changes. Respiratory is going to monitor oxygen levels, monitor for blood clots, and also monitor for any signs of aspiration. Pharmacy will provide medication education and ensure proper medications are prescribed and administered.
Your case managers are like your navigators. They will meet with you from day one and to begin prepping you for your flight descent. They will assist with getting you any medical equipment needed upon discharge. and setting you up with therapy or medical services you might need.
All right, so your flight attendants are your therapists. They will be with you throughout your stay and will be preparing you for discharge. While in inpatient rehab, you will receive at least 2 disciplines of therapy, and most of our stroke patients receive all 3 disciplines. So in occupational therapy, their main focus is going to be on ADLs, or activities of daily living, which include bathing, dressing, toileting, eating, and oral care. They will also focus on your instrumental activities of daily living, which include household tasks like cooking, cleaning, and laundry. IADLs also include being able to manage money and medications if needed upon discharge. While the main focus of OT is ADLs and IADLs, they also work on your ability to move and strengthening so that you are able to complete your daily task. For example, working on balance so that you can pull up your pants, or working on arm strengthening so that you can sand and cook. In physical therapy, the main focus is on mobility. Everyone's mobility will look different after having a stroke, so this could include things such as propelling a wheelchair, needing to work on standing upright unsupported, your standing balance, and lower body strengthening, which can progress you towards walking. Lastly, we have speech therapy, which will focus on any cognitive task related to your daily life or swallowing deficits. Speech therapy may perform a swallow study during your stay if needed.
All right, at Encompass Health, we offer a multitude of specialized technology for your stroke survivors. We're gonna call these our complementary items. First, we have our ADL suite, where we simulate and practice real-world tasks in a safe environment under the direction of therapists. Next, we have our BearyHab, which is a specialized mat that allows us to facilitate early weight bearing in a safe environment in which there's absolutely no risk of falling. This mat allows us to make tasks easier or harder depending on how the patient progresses. Next, we have the Bioness Bits, which is an interactive tool to challenge one's balance from sitting or standing. We can also work on cognition and visual deficits. The LightGait is a mobility device that allows therapists to initiate early gait training while ensuring that the patient and therapist are safe. Next, we have our VitalStim, which is electrical therapy that targets swallowing muscles to assist in advancing a patient's diet and liquids.
So one of our big ticket complementary items is the BERT, which stands for Barrett Upper Extremity Robotic Trainer. This allows patients to move their affected upper extremity in a gravity-eliminated setting while being cognitively stimulated through virtual activities. These activities engage the patient, allowing for increased neural pathways to be created. Patients really enjoy the BERT because it allows them to see greater ranges of movement in that affected upper extremity. And as the patient progresses, we can adjust the settings to provide less assistance and even resistance based on the patient's level.
Our next big ticket item is the Bioness H200. It is an electrical simulation device that can be used to improve hand function, reduce muscle spasms, and maintain hand range of motion and re-educate muscles. The H200 is different than your usual eStim device, in which it can be worn and operated like a prosthesis. We typically use this device with our stroke patients when performing tasks like bringing a cup to your mouth. We currently have the L300 on order, which can be used for your lower extremity.
Up next, we have the Vector, which is a body support system. The Vector provides a safe environment thanks to its fall protection system while working on mobility. The fall system is able to detect a sudden drop, which then locks the rope to prevent the patient from falling to the ground. The Vector is also able to lift weight off of the patient. Both of these functions allow us to work on various treatments, strategies such as mobility, balance, and motor control. The Vector provides a safe environment which helps boost our patients' confidence. We actually have the longest Vector track of any inpatient rehab in town.
All right, another big ticket item we have is our neurodevelopmental treatment. NDT is a highly regarded holistic clinical practice approach informed by current and evolving research. It emphasizes individual therapeutic handling based on movement analysis for individuals with neurological conditions. As an NDT therapist, we are trained to analyze our patients' movements, including postural control, alignment, muscle activation, and compensatory strategies. This technique takes a lot of skill and studying in order to apply properly in our patients. This course you have to apply to and you have to be accepted. It takes about 2 to 3 weeks to get this certification, and we are very lucky to have 2 NDT therapists on staff, which are Courtney and I. We also hope to grow our NDT team at Encompass.
So while on your flight to recovery, you might experience some turbulence. Some types of turbulence you can experience include blood pressure difficulties, so blood pressure being too high or too low. You might have to have a change in your diet texture, or even the possibility of a peg tube or feeding tube. You might experience some anxiety or depression following such a life-changing event. You can also have some visual changes which can lead to dizziness depending on the location of the stroke. According to the American Stroke Association, the most rapid recovery typically happens in the first 3 to 4 months, but with therapy, patients can expect to continue to make progress after that. It's important to remember that every stroke is different and everyone progresses at different rates.
This is your captain speaking. Please prepare for your flight to descent. This is when you're preparing to go home. Before discharging, you will go through stroke education, where you and your family can attend a stroke class, where you'll be getting a booklet that is titled Life After Stroke. The class will review this book and answer any questions you or your family may have. Family training, which is where your family can come and see your progress with therapy and also get some hands-on learning. We can also do home assessments, which often we do virtually, where that way we can look at any home modifications that might need to occur before you go home. We can also assist with ordering equipment provided by insurance. And then in this picture here, you see our health journal, which is called our With Book. Every patient at Encompass gets this, and in this book, you receive your home exercise program, your medications, and your discharge instructions.
So once you leave inpatient rehab, the therapy journey still continues. Options that are frequently chosen are home health or outpatient therapy services. Some choose to do home health first so that they can get more comfortable within their environment and then progress to those outpatient services. There are many factors that are considered when choosing the right choice for you or your loved one, and your flight crew will guide you in that decision. Thank you for choosing Encompass Airlines, and we wish you a safe trip on your journey to recovery.
Thank you so much, Miss Callie, Miss Courtney. That was an amazing presentation. I loved the videos. Hope everybody else enjoyed it as well. So this is a final reminder to fill out your booth tracking cards and turn them into the prize drawing basket. The drawing will be at 1:30 p.m. sharp. We have multiple prizes and giveaways, so there's not just going to be one winner. However, the grand prize winner will get an Apple iWatch, which is just going to be a really cool tool to help you monitor your health and wellness. So join us at 1:30 for prizes. Make sure you turn in your cards, any last-minute booths. I appreciate everyone for being here, and thank you so much, and we'll see you at 1:30. Okay, so we're gonna start with a t-shirt. You get a BEFAST t-shirt. All right, the winner of the first giveaway, his t-shirt, is Charles Jones. If Charles is here still, you can come up and get your t-shirt. Otherwise, we will mail it to him. Too much. Next, we're going to be giving away, courtesy of the YMCA, we have a free 3-month membership to the Y. Free 3-month membership to the Y. India Tucker. Grab me a pen. Send me a pen. Such a nerd. Okay. Next, we have a Ochsner LSU Health backpack. And the winner of the backpack is Brian Barber. Next, we will do an umbrella. Harper, do you want to draw? The winner of the umbrella is Bernester Cooley. Next, we'll do another 3-month free membership to the YMCA. Ms. Helen Cool. Helen Cole, free YMCA membership for 3 months. Next, we'll do another t-shirt. Dr. Himanshu Chokhawala. You can give it to his kids. Next, we have another backpack. They are enjoying themselves. What did I say, backpack? Winner of the backpack is Deborah Shakesnyder. Let's do another 3-month free membership to the YMCA. Three-month free membership to the YMCA, Ms. Emma Mauser. That's my mother-in-law. Umbrella. The umbrella, right? All right, winner of the umbrella is Larry Roche. Congratulations.
I'm being blinded by that stupid projector.
Huh? We will do another t-shirt next. For the t-shirt. Winner of the t-shirt is Miss Sarah Gilmore. You're a winner. Next, we have one free 50-minute session to Stretch Lab Shreveport. Thank you, Stretch Lab, for donating that. Winner of the free 50-minute stretch is Miss Julie Burton. You can go give that to the stretch lady. Okay. We will do another t-shirt. Miss Angela Lewis. We have one more 3-month free membership to the YMCA. Miss Cynthia Burrows. No, hey, no. That's a free 3-month free membership to the YMCA. Okay, it's time for the grand prize drawing for the Apple iWatch. Is everybody ready? I know these kids are. Not too fast, slow it down or it's not gonna mix them up. Winner of the Apple iWatch is Miss Pamela Carroll. Sorry. And that's it. Thank you so much, everybody. That is all of our prize drawing winners. We will get in contact with those that were not physically here still. They luckily all filled out their information on their cards. We just want to thank you so much for participating. Thank you for coming. We loved having you. I hope everyone feels like they learned something and grew as a community in your stroke awareness and your health and wellness maintenance. So hopefully we will do this again next year. Please reach out to us if you have any questions. Thank you especially to our sponsors, to the YMCA. First and foremost, thank you so much. Thank you to Pulsera, Encompass, ADOC. Thank you to Stretch Lab for coming and donating a prize as well. And thank you to all our volunteers. So I appreciate all of you.